has to be, the endpoint should be clearly visible. So you can see the image. This is taken after 9 weeks. The fetus is focused, whole fetus is focused in sagittal section. We are seeing whole fetus starting from the crown, the top where you're placing your caliper, to the rump where you have to ending the endpoint. So whole length, that is the greatest length of fetus is taken. And in neck rump length, it is taken from the neck to the rump between 6 to 9 weeks. So these are few images between 6 to 8 weeks, that is early period, where we have to take neck, rump, neck. So we are taking the greatest straight length of the embryo, that is the neck rump length. And this is 6 weeks, 4 days pregnancy, where we have to take the NRL. This is also before 9 weeks. So NRL is taken in these images. So this is 9 weeks pregnancy. Date the pregnancy after 9 weeks, taking CRL. Measure the CRL precisely so that you can assign accurately the gestational age to the patient sonologically. Next is, this is the 10 weeks fetus. So by 10 weeks, we always tell the embryo is now referred to as fetus. So after 10 weeks, we tell it it's the fetal period has started. So during 10 weeks, like majority of structures have been developed. That means spine has developed, upper limb, lower limb birds have developed. Even the cranium has distinctly formed with the choroid plexus, even the primitive gut, and there will be umbilical mid-gut herniation, that is physiological herniation. Most of the things we will see. So we have read about gestational sac, how to identify the normal features of gestational sac, and it usually appears between 4 weeks, 3 days to 4 weeks, 5 days of menstrual age, and it grows by 1 millimeter per day. Yolk sac, usually it is a structure which acts as an anatomical landmark to identify the embryo, and inside the embryo to detect the cardiac activity. It appears between 5 weeks, 1 day to 5 weeks, 5 days of menstrual age. Embryo with cardiac activity, usually we see between 6 weeks to 6 weeks, 5 days. Amnion we see between 7 weeks. So next we'll move on to different symptoms that we come across in early pregnancy period. About 20% patient will have pain or bleeding per vagina or both of the symptoms. 50% continue into normal pregnancy despite of blood loss. And there are many causes are there, obstetric causes like miscarriage, ectopic pregnancy, ruptured corpus luteal cyst, ovarian torsion will cause severe pain. Similarly, we also have differential diagnosis like non-gynecological causes like cystitis, appendicitis, ureteric stone, constipation. So symptoms alone cannot help us to know the ectopic pregnancy or miscarriage. We have to take the help of imaging modality. The first imaging modality is ultrasound, which will help us to know whether the pregnancy location, if it is present outside the uterus, whether the pregnancy is viable or non-viable, whether there is miscarriage. That is made out. The diagnosis can be made out by taking the help of ultrasound. So as I mentioned, there are certain terminologies that we all have to speak in the same language. So it will be easy to everyone will understand what we are speaking. So viable pregnancy, when the cardiac activity is present, the pregnancy is said to be viable. When you are not getting cardiac activity, then it is a non-viable pregnancy. It can be failed intrauterine pregnancy. It can be ectopic pregnancy, molar pregnancy. Sometimes there is a term also used like intrauterine pregnancy of uncertain viability, when you are not sure whether it is viable intrauterine pregnancy, whether it is non-viable intrauterine pregnancy, then we use a term called intrauterine pregnancy of uncertain viability. As you all know, ectopic pregnancy, when the pregnancy is implanted outside the uterine cavity. Heterotropic pregnancy, it is at the same time when we are getting a G-sac inside the uterine cavity and also pregnancy outside the uterine cavity, then we tell us that it is a heterotropic pregnancy. Pregnancy of unknown location, when the woman come with positive pregnancy test, and when you're doing scan to locate the pregnancy, we are neither getting a G-sac inside the uterine cavity, nor we are getting a G-sac outside the uterine cavity. You do not know where is the location of pregnancy, then we term as pregnancy of unknown location. What is miscarriage? So the spontaneous loss of pregnancy before it would be able to survive independently, that is before 24 weeks of gestation or before the fetal weight is more than equals to 500 grams. The fundamental principle is of pregnancy is that first do no harm. Do not do any harm to the viable pregnancy. So do not make any misdiagnosis of miscarriage. If you do any misdiagnosis of miscarriage, you will lead to termination of pregnancy, of a viable pregnancy. Unknowingly, you may terminate the pregnancy. That's why everyone has to follow the strict cutoff or criteria to diagnose miscarriage. Not only you have to follow the strict criteria to diagnose miscarriage at initial scan, but also we have to follow the time-based criteria to diagnose miscarriage during the follow-up scan if your initial scan is inconclusive. That is what I mean. Like everyone has to know what are the criteria, how to diagnose miscarriage at the initial scan itself. That means at first scan itself. If in the first scan you are confused, you're not sure, then when to plan the follow-up scan. In follow-up scan, how to diagnose miscarriage, that is important. By doing that, you are very sure with your diagnosis and you are not doing any harm to the patient by labeling it by misdiagnosis of miscarriage. So these are the guidelines, or these are the criteria. You have to know, you have to follow this strict criteria, you have to remember and you have to follow. So these are the criteria to diagnose miscarriage on transvaginal scanning at initial scan. That means at first scan itself, you can say this is a patient, this is a scan for a which indicates it's a miscarriage. There is a miscarriage of pregnancy. So what are these criteria? When the initial scan you have done, you are getting a mean sac diameter which is more than equals to 25 millimeter, and it's a empty mean G sac, doesn't have any structure that is yolk sac, neither embryo is there or a fetal pole is there, then you can label it as miscarriage. If the initial scan where the embryo is more than equals to 7 millimeter without any evidence of fetal cardiac activity, or if a woman is having regular menstruation and she comes with a positive pregnancy test at 70 days after her LMP, you have done a scan, the mean sac diameter is coming more than equals to 18 millimeter, and you're not getting embryo, or you're getting an embryo which is more than equals to 3 millimeter, but you're not getting fetal cardiac activity, then it is a condition or it is a case of miscarriage, you can label it. But still, if you're not sure, don't jump into diagnosis of miscarriage. You can go do a repeat scan, scan her after 7 days and see the finding, compare the finding with the previous scan, and then you make a diagnosis of miscarriage and give your whatever opinion or intervention, what you want to start, you can start it. Or always take the help of second operator to make a diagnosis of miscarriage. So this is a video, you can see the video like showing the like a fetus, like transvaginal scan. You can see the embryo is seen, thorough scanning was done, the cardiac activities was not there, there was no cardiac activity. Then CR, that is it's like CRL is taken, and this comes to around 11 millimeter, that means it is more than equals to 7 millimeter, but there is no cardiac activity. So that is a sign to tell it's a case of miscarriage. If you're not sure, you also take the help of second operator. You can ask her to follow up after 7 days and you make a diagnosis. Or you can put a color Doppler if there is no activity, then see there is any Doppler activities there or not. That is just optional. Otherwise, you can scan after 7 days and confirm it, or you can take the help of second operator. Now, this is like when to call when the initial scan is inconclusive, and when are you planning to for a follow-up scan, and what are the criteria that is that will help us to tell this is a case of miscarriage. This is called time-based criteria to diagnose miscarriage on follow-up scan, transvaginal scan, when the initial scan was inconclusive. So when there is no embryo with fetal heart activity more than equals to 14 days after an initial scan that showed a gestation sac without a yolk sac, no embryo with fetal heart activity or cardiac activity more than equals to 11 days after an initial scan that showed a G-sac with a yolk sac, then it is a case of miscarriage. Or initial scan shows a embryo. When you have repeated or you have done a follow-up scan after 7 days, there is no appearance of fetal cardiac activity, or initial scan where the G-sac diameter is more than equals to 2 millimeter mean sac diameter with or without yolk sac. You have done a repeat scan after 7 days, you're not getting embryo with cardiac activity, or when the initial scan where the mean sac diameter is less than 12 millimeter and you have done a repeat scan after 2 weeks, even there is, you see after 2 weeks also there is no doubling of mean sac diameter, then you can label it as miscarriage. So these are the ultrasound image to diagnose miscarriage at initial scan itself. You remember this images, keep in your mind, save in your mind, that will help you to diagnose. These are the two important criteria at the initial scan to label it a case of miscarriage. When the mean sac diameter is more than equals to 25 millimeter, you're not seeing anything inside the G sac, neither a yolk sac or embryo or a fetal pole, then you can label it as miscarriage. This is a important, another second important criteria, that is when the CR is more than equals to 7 millimeter, but there is no appearance of cardiac activity, then it is a case of miscarriage. So these are few criteria that is suggestive of miscarriage. That means it's a warning. So maybe this pregnancy may become a viable intrauterine pregnancy or may not be a viable intrauterine pregnancy. No, it may be a non-viable intrauterine pregnancy. So it is intrauterine pregnancy of uncertain viability. By seeing this criteria, you can make a diagnosis, but also always ask her to follow up and depend on time-based criteria. So when the CRL of less than 7 millimeter and no heartbeat, or mean sac diameter is between 16 to 24 millimeter and there is no appearance of embryo, or the pregnancy is more than equals to 6 weeks after LMP, but there is absence of embryo, on when the yolk sac is very abnormally very large, more than 7 millimeter yolk sac you are getting, or the amniotic cavity doesn't have the embryo inside it, so it is an empty amnion sign, or when there is small gestation sac in relationship to the size of embryo. That means the difference between mean sac diameter and CRL is less than 5 millimeter, or when you're getting a G-sac at the lower part of the uterus, that means in the cervix, either it can be cervical ectopic or a caesarean scar ectopic, or when you're getting a G-sac, which is crumpled, irregular, smooth margins were not maintained, or you're getting a subchorionic hematoma, which where like more than 50% of G-sac is separated from the attachment of decidua, or the subchorionic hematoma is more than 60 ml. These are the conditions which, when these sonological parameters are there, that indicates patient may have miscarriage in future. So we can see this is a like the above picture where the G-sac is around 19 millimeter. That means it is less than 25 millimeter, and you can see the smoothness. There is no smoothness of wall maintained. The wall has become irregular. So in this condition, you can repeat the scan after 7 days. After 7 days, see if nothing is appearing, then you can label it miscarriage. So this is the CRL. Here CRL is 5.85 millimeter. That means the embryo is there, and this embryo is there, and it is 5.85 millimeter. It is 6 weeks, 3 days pregnancy, but cardiac activities was not evident here. Then here also, this is at present, this is signs suggestive of like miscarriage. It is not diagnostic. It is suggesting us like probably the lady will have miscarriage in future. So you can do after 7 days, call this lady, do scan and see whether cardiac activity is appearing or it's not appearing. If it is not appearing after 7 days of your follow-up scan, that means according to time-based criteria, you can label her as having miscarriage. Now this is again the empty amnion sign. You can see the amniotic cavity here. Yolk sac is there. The blips are there, but embryo is not there. So this is also suggestive of having miscarriage. So this is a small G-sac. When the difference between this mean sac diameter and CRL is taken, then it comes to less than 5 millimeter. That means the small G-sac is there in relationship to embryo. That is also a sign suggestive of having miscarriage in future. So this is a video. You can see the video how the GSAC is separated, and it is separated from its attachment. So there is, so you can see this is the GSAC separated from the decidual attachment. There is a hypoechoic crescent shape collection is there. So this is a video showing subchorionic hematoma. So this is the image showing subchorionic hematoma. This is a crescent shape image, hypoechoic with the echogenic debris is there. So this is a sign of subchorionic hematoma. And it depends, like subchorionic hematoma also depend, like when the amount of blood bleeding is more than 60 ml, or when 2/3 of 50, more than 50% sac is separated, then it is very warning to obstetrician. Now we'll move on to abnormal pregnancy and its ultrasound features of abnormal pregnancy, that is ectopic pregnancy and the molar pregnancy. So as you all know, the common location of ectopic pregnancy is tubal. So for 95 to 96% cases, you will have tubal ectopic pregnancy. In 3%, you will have ovarian ectopic. In less than 1%, you will be getting cervical ectopic, and the incidence of cesarean scar ectopic is less than 1%, and abdominal ectopic is 1%. So ectopic pregnancy imaging is not only enough. So we have to take proper history, do general examination, physical examination, abdominal examination, then you go to imaging modality. So overall, if you examine a patient starting from history, your examination and imaging, oh, whole will help, everything will help us to diagnose ectopic pregnancy. As it is a life-threatening condition, we have to have proper diagnosis of ectopic pregnancy so that we can do early intervention. So if a lady is coming with a urine pregnancy test with symptoms like amenorrhea history is there, and there is symptom of lower abdominal pain, vaginal bleeding, you have done pregnancy test, it comes positive, and she may be hemodynamically stable, she may be unstable, she may come with various presentation to us. And in those conditions, if you do ultrasound, if you see in ultrasound, the pregnancy test is positive, biochemically it is positive. And if you have done ultrasound, you are not seeing anything inside the uterine cavity. That means you are not getting a GSAC inside the uterine cavity. There is no evidence of intrauterine pregnancy, but you'll be getting a like different types of endometrium will be there, the trilaminar, thickened endometrium, or you may get a pseudo-gestational sac. But sonologically, you may get other signs of various presentation of ectopic pregnancy. The most common sonological finding is in 60% cases, you will get a heterogeneous adnexal mass that is called as blob sign. Sometimes you will get in 20% cases, if you're lucky enough, you will see exactly a GSAC outside the uterus, and it will be having a hyperechogenic rim, and it will be empty. Most of the time it will be empty GSAC. It is Bagel signs. That in 20% cases, if you're still very lucky enough, you may see a extrauterine GSAC with a yolk sac. Embryo will be there, sometimes with cardiac activity or without cardiac activity. That is easy to make a diagnosis of ectopic pregnancy. And in severe cases, you may get hemoperiton, like patient coming with severe ectopic pregnancy, like ruptured ectopic pregnancy with hemodynamic instability is there. In those conditions, you may see hemoperitoneum, that blood collection inside the peritoneal cavities surrounding the uterus, anterior to the uterus, posterior to the uterus. Even in Morrison pouch patient will come with the serious condition. So this is an image showing the extrauterine inhomogeneous, like heterogeneous mass, blob sign. And if you put Doppler in those conditions, you can see ring of fire. So extrauterine, you will be getting a GSAC, and there is presence of increased trophoblastic flow, and with increased vascularity, you can see a sac. You can see this GSAC is present outside the uterine cavity. It is lined by hyperechogenic rim, and it is sonolucent at center. And if you put Doppler, you can see how much vascularity it is there. So this is called ring of fire sign. Then sometimes there is a lot of confusion. As we know, the most common site is tubal ectopic, but the sac will be very close to the ovary. So it will create confusion whether it is, though it is extrauterine, whether it is arising from ovary or it's a tubal ectopic. So you can do sliding sign. Just gently move the transvaginal probe and see what is happening. So you can see the still image. You are getting a GSAC here, which is present extrauterine. This is the uterus. You are getting outside the uterus, GSAC is there. And you can see, identify this structure. This is ovary because it is present in front of the iliac vessel. There are follicles are there. So it is ovary. Now, confusion starts from here, whether this G-sac is inside the ovary or it's outside the ovary. How to know whether it is extra ovarian or it is inside the ovary, that is ovarian ectopic. Do sliding sign. So just gently move the probe and see what is happening.
Not audible.
Hello, Jasmina, are you muted? Hello, we can't hear you.
I think video is not working. She is making it now.
But she's unmuted, no? She can go on speaking.
I think she's logging in again.
I think she is logging in
Yeah.
again.
Yeah.
Start sharing. Yes. We can't hear you. Are you muted? Unmute yourself.
Yes, sir. Yes, sir. So I was going from which slide, sir? Which slide I have to start?
You were on the ring of fire. You know?
Okay, sir. Okay. Okay.
Blob sign, blob sign.
Blob sign. Okay. Okay.
You were sliding.
Just after blob sign.
Slides are moving, huh?
No, you are showing the blob sign.
It
No,
had
Before
been-
this.
and you
Before
were going to you were going to show us how to differentiate the ovarian structure from an ectopic structure.
Okay, sir. Okay.
And
My slides are moving.
No,
Right.
no, they are not
Not yet.
moving.
Not moving. 1 minute. I will go back again.
Ma'am, it was slide number 51.
Okay. I will. Okay. 1 minute. Let me share once again. See, my slides are moving,
We can see the slide.
but it's not moving, I think.
And you just
No,
click
it's
on the
moving?
slide. Yes, yes. Now it is.
Yeah, it's moving. It's moving.
Now it is
1 minute.
moving.
Okay. Okay. So
Just
You were
before
on
this.
now
Before
slides are
this.
visible.
This
Before
one,
this.
this one. This
This
one, this
one.
one. Yeah, this one. Last one was this.
Okay, okay. So this is like a ring of fire. Here you can see the sac. Let me run once again.
You were at the point of showing the sliding sign.
the next
Sliding
slide.
sign. Oh,
Yeah,
okay,
the
okay.
next one. Next one.
Okay, okay, then okay. So as I mentioned, like sliding sign is to differentiate a tubal ectopic from ovarian ectopic. So we have to move gently the probe and see whether the probe is while moving the probe, whether the G-sac is going away from the ovary or it's moving along with the ovary. If it is moving and if it is moving away from the ovary, then it is tubal ectopic. So you can see in this image, the G-sac is going away from the ovary. It's moving away from the ovary. So it's a tubal ectopic. It's not inside the ovary. It's again hanged, I think. It's not moving again. It's moving, madam. Slides are moving.
Yes.
Yeah, another one has come.
Uh-huh. Okay, then this is like you can see in this image, like uterine cavity is there. It's empty uterine cavity, and you can see hemoperitoneum outside the uterine cavity. You can see like in front of uterus, even backside of uterus, like anechoic spaces are there. Even echogenic debris is there. This is nothing but ectopic pregnancy coming in severe condition, serious condition, life-threatening condition with a ruptured ectopic having hemoperitoneum. So management, this is very busy slide, so I'm not going into detail of this management. So you all will be knowing. So management of ectopic pregnancy depends upon the initial beta HCG value, your mean sac diameter, the hemodynamic stability of the patient. So usually when the beta HCG is less than 1500 international unit per ml and the sac diameter is less than 3 centimeter, then we go with expected management. If it is sac diameter is between 3 to 5 centimeter and the beta HCG value is between 1500 to 5000 and hemodynamically stable patient, we go with the medical management with methotrexate. And when the beta HCG value is more than 5000 or the sac diameter is more than 5 centimeter and patient is hemodynamically unstable, in those conditions, we go with surgical management. Then the most important thing is that the pregnancy of unknown location. And this term is used to describe women with a positive pregnancy test who have no evidence of either an intrauterine or extrauterine pregnancy on transvaginal ultrasound. So usually this patient will come with a history of amenorrhea. You have done pregnancy test, it comes positive. When you do scan, you do not see any GSAC, neither inside the uterus nor outside the uterus. So usually what imaging findings you will be getting? Either you see nothing inside the uterine cavity, either a thick endometrium is there or a pseudogestation sac or a thin endometrium will be there. And outside the uterine cavity, you will get a normal ovary with the corpus luteum, or uterus and ovary will be normal. Even the hemodynamic condition of the patient will be stable. There won't be any hemoperitoneum. So how to manage this type of condition? So there are many algorithms are there to manage. One of is that do serum progesterone values, see the levels. If it is less than 10 international unit per ml, do nothing. It's a failing pregnancy. Wherever it is failing pregnancy. Ask the lady to come after 2 weeks and do urine pregnancy test. Another M4 model. These are like different articles or research articles who have given prediction models. So M4 model where the initial HCG is done, and after 48 hours, as you all know, the HCG doubles by 48 hours. So after 48 hours, we have to take the HCG 48 hours value. Then the ratio was calculated by dividing the HCG values taken at coming at 48 hours divided by HCG of 0 hours. Then the ratio will help us to predict what will happen in future. So when the HCG ratio is less than 0.87, it is high likely that the patient will be having a failing pregnancy, wherever is the location, whether it is intrauterine or extrauterine, it is going to fail. So nothing has to be done. Discharge the patient, call her after 2 weeks, do urine pregnancy test and see. When the ratio is more than 1.66, then it is high likely, it predicts that it is an upcoming or ongoing pregnancy is going to appear. So nothing has to be done, no need to get worried. Am I audible?
Yes, you are audible. Huh?
Then when the ratio is between more than equals to 0.87 and it is less than equal to 1.66, this is the most dangerous part. So it indicates that the woman is going to have ectopic pregnancy. In that condition, you should not leave this lady home. You should not discharge the patient. Do serial beta HCG levels every 48 hours. Do ultrasound after every 48 hours till you reach the discriminatory zone. So discriminatory zone is the level of HCG where in 99% chances like you will be getting intrauterine pregnancy. So do serial beta HCG till you reach the discriminatory zone. The discriminatory zone at present, the discriminatory zone is labeled up to 3,500 international unit per ml. So do serial beta HCG values. See, it has reached up to 3,500, and simultaneously go do scanning for the patient every 48 hours. See where is appearing. If the GSAC is appearing inside the uterine cavity, then it has to be managed like intrauterine pregnancy. If GSAC is appearing outside the uterine cavity, it's coming as ectopic, then manage according to the criteria what I mentioned in my previous slide. Then there is another model like M6 model, where both the things like progesterone values are taken into consideration, and even the HCG ratio was taken. So step 1, the progesterone values are taken. If it is less than equals to 2 nanogram per ml, nothing, no need to worry, just discharge the patient. It's a failing pregnancy of unknown location. In step 2, you have to take the ratio, 48 hours HCG values, then calculate the ratio and see where it falls, whether it is like high risk patient, whether it is low risk, failing pregnancy of unknown location, whether it falls in that more than 1.66. It's the upcoming intrauterine pregnancy. Manage accordingly, as I mentioned in my previous slide. So the other abnormal pregnancy that we see in early pregnancy is molar pregnancy. The incidence is 1 is to 1500 pregnancies, and there are 2 types of mole: complete mole and partial mole. Complete mole, it is always paternal origin, having a genotype of 46XX, whereas partial mole is paternal and maternal origin, having a triploidy type of genotype. And it is very easy to diagnose complete mole. 95% cases will diagnose it very easily by seeing classic appearance of snowstorm of bunch of grapes with bilateral lutein cyst in the ovaries. The difficulty arises to diagnose partial mole. Only 20% cases we can diagnose partial mole, having a big placenta with a focal trophoblastic proliferation with multiple cystic spaces in the placenta, along with a growth restricted fetus, or having fetus with anomalous fetus. You can see that will help us to know the partial mole. So I have come to the end of my lecture. I want to highlight the key points here. The first evidence of an intrauterine pregnancy can be seen is around by 4 weeks by transvaginal scan, and you will see little later in transabdominal scan. At 4 weeks, we'll get a tiny mean sac diameter G-sac that is around 2 millimeter size, and the normal G-sac grows by 1 millimeter per day. And we all have to follow the correct terminology to describe the early pregnancy event. We have to follow strict criteria for initial scan and the time-based criteria in the follow-up scan to diagnose miscarriage. And the most common ultrasound appearance of ectopic pregnancy is empty uterine cavity with the heterogeneous mass, that is the blob sign. So thank you all.
Excellent
Thank you.
presentation. Thank you, Jasmina Begum. And
Yes, madam.
Yes. Now, shall we allow questions? Which
I think let Dr. Khurana
Okay.
comments.
Yes.
If he has anything more to say about this subject.
But yes, while Dr. Khurana is commenting, Sambit, shall we have the post-poll questions now? Or
Yeah,
after
sure, ma'am. Sure, ma'am. I will.
Yes.
I'm launching the poll questions.
My congratulations to the entire team for putting together yet another very, very, very informative session. It is a pleasure to be an audience to such an excellent talk. We had a fabulous speaker, fabulous slides, fabulous flow of information, and most importantly, the right pace. It's very rare that we get so much information at the right pace. And my congratulations, Dr. Jasmina Begum, for such an excellent talk.
Thank you very much, sir.
The content was absolutely fantastic. I just wish I was born in today's era where I could learn from teachers like you and have everything ready-made without having to make the effort that we had to make in my time. Thank you also for teaching us that we can do so much at medium level technology. And importantly, like I said, to be very liberal with transvaginal scanning, to make sure that we use the flow charts to realize that mathematics is so important in early pregnancy. And also to keep in perspective the fact that we should truly, in the Indian context, scan every single patient when she comes to us in the beginning of pregnancy because of the problem with dating. The calendars that we as a nation carry in our heads consist of either a calendar of personal events, a calendar of festivals, or a calendar of some great national event. And therefore, we never have a correct dating of pregnancy, and we get stuck at the end of pregnancy. And if we were to put every single patient for a quick scan, magnify appropriately, do the neck rump length or the crown rump length as required, we will have a pregnancy dated with just one little scratch on one piece of paper. That piece of paper will tell us whether at the end of that pregnancy, this baby is mature or premature. I mean, that is really the first thing. The second thing is, can she go home to wherever she stays, or is she going to die of an ectopic pregnancy? We confirm an intrauterine pregnancy, and with the incidence of blocked tube secondary to tuberculosis, the importance of confirming an intrauterine pregnancy can never be overstated. It's truly an extremely important thing to confirm these two things. We also learned that we should not get alarmed by the fact that a heart rate might be slower in early pregnancy, and the presence of a heart rate is enough to tell us that this is doing fine. This is something that is missed by most workers, and we start getting worried about a bradycardia. And of course, we are in a hurry to label a pregnancy as a miscarriage, and that should not be the practice. What we must also learn, that we have now learned to differentiate words very clearly in their connotation. We've learned 3 words: embryo before 10 weeks, fetus beyond 10 weeks. The second concept we have learned is that there is a miscarriage, which is a natural event, and an abortion, which is an artificial event induced between the patient and the doctor, or the patient and the drug that she takes. So the word miscarriage will now be used instead, a word like spontaneous miscarriage, missed miscarriage, inevitable miscarriage, and incomplete miscarriage, rather than spontaneous abortion. We will not use the word spontaneous abortion. We will use what everybody all over the world can understand. We've also learned that there can be a pregnancy which is there, but we don't see, and that's the pregnancy of unknown location, and that we have a protocol for this. And most importantly, the M6 model, which you can download on your smartphones. And it's very simple these days to therefore classify these pregnancies. So particularly when you're sitting in a remote area, you realize that all you have is a lab that does good work and can give you a progesterone within 4 hours, because it's a cheap, inexpensive test. And that tells you that this patient doesn't have to stay on where she is. She can go home if she falls in the right category. I don't have to put her on bed rest. I don't have to hospitalize her, and I don't have to make a decision. I can wait safely. So this M6 is really an excellent program to go by. And of course, we've learned that we have to open our minds. And the only way to diagnose ectopics is to think ectopic. If we keep thinking ectopic, we can really never go wrong. And we must never dismiss as trivial any patient who has a symptom in early pregnancy. I mean, apart from perhaps emesis, every other symptom in pregnancy, in early pregnancy, needs appropriate attention. So congratulations for this absolutely marvelous talk. And like I said, I wish I had heard this talk 30 years ago. I wouldn't have had to make such an effort and struggled so much. Thank you very much. And my congratulations for yet another successful event by our training program, which is being so beautifully organized in Odisha in these next few weeks.
Yes, thank you so much, Professor Khurana, and for putting into a nutshell all that Jasmina has said. And there's one chat question, as well as also I had 2 questions to ask. A little more clarification regarding uterine scar pregnancies, since cesarean sections are on the rise, and so when to suspect them, and in our ultrasound picture, what are the typical pictures of a scar pregnancy? And then there's another question that I had. The heart rates in the first trimester, can bradycardia and or tachycardia, beyond the rates that she mentioned, predict aneuploidy in the first trimester itself? These are the 2 questions, which of course it's also relevant for our specialists, that regarding the appearance of scar pregnancy symptoms as well as ultrasound pictures, and the heart rates. She mentioned that it's between 110 and 140, isn't it? So if there's tachycardia, do we predict a certain variety of aneuploidy, and The bradycardia also, trisomy, I think 16, trisomy 21 or 18
Yeah.
would have.
Well,
Anyway,
I can give a brief answer to the heart rate. We know that trisomy 13 fetuses will show tachycardia and usually beyond 180 beats per minute after 10 to 11 weeks of pregnancy. So at this window of 4 to 10 weeks, the tachycardia may not be a reliable sign, and therefore that is important. And the scar, I would, Dr. Jasmina, go right ahead. I didn't think we gave you enough time to attend to scar pregnancy. So this is your opportunity to tell us more about scar pregnancy morphology and management. Is she able, Dr. Jasmina?
Jasmina, I was expecting some videos on scar pregnancy, but there, of course, you may not have one at the present. But then our specialists need to be aware of this because lots of cesarean sections are being done, and scar pregnancy.
Actually, when the sac is located in abnormally, like we have to see that the sac which is situated lower down, and of course we can always see a CS scar, and the adherent sometimes also I have seen G sac attached to the scar also, because just below the neck it will be attached. So these are the unfortunately I don't have any picture here, but CS scar is, because this is a very common. It will become very common nowadays as the number of CS is increasing day by day. So
there's a chat question. Sometimes patient demand UPT negative 2 to 3 months. So please do USG to rule out pregnancy, as it happened to her in the last pregnancy also. Narottam, are you there? Can you please clarify what you want to say? That means there's a patient with amenorrhea. Her UPT is negative and she's demanding an ultrasound to rule out pregnancy. Is that it?
Yes. Yes, ma'am. Yes.
Yes, and because she has gone through it and she got a pregnancy in her last pregnancy also. This
yes, in her last one also UPT came negative. Saying as she was saying, in her last pregnancy also UPT came negative for 2 to 3 months. But after ultrasound, it detected that she is having pregnancy. Is it possible?
Maybe she will be having irregular cycles. I think proper history is important here.
Yes. There is no doubt that when the HCG levels are very high, in excess of 100,000 units, they might escape detection by the current technology that we use for the detection of urinary and serum HCG. And usually it's the urinary HCG kits that don't detect very high. They have blocking antibodies to them, and because then elution does not take place, we miss out on a positive pregnancy test. But we would never miss out on a serum HCG. And there's no doubt that serum HCG would be more indicative. So in such patients, I would be inclined to do a serum HCG rather than an ultrasound scan, because it is possible that she has irregular cycles, like Dr. Kanogo mentioned. And therefore, in that case, I don't see it today, but I might see a sac tomorrow. But the HCG will still be beyond the non-pregnant levels today. So whenever a patient has a dilemma like this, the first thing I would ask her today is to do a serum beta HCG, and then to repeat the urine HCG after a week, rather than the effort of going through an ultrasound scan.
There's another question: is how to identify cervical ectopic?
I think this question relates to the fact is, how do I differentiate between a cervical ectopic and an inevitable miscarriage lying within the cervical canal or at the internal os? So the best thing again is to make sure that you use the wonderful principle that Dr. Jasmina highlighted, that the vaginal scan is a dynamic scan. If I push on the cervix or on the uterus, and I'm able to move the entire gestational sac up and down in the cavity, then I know that this is definitely an inevitable miscarriage. On the other hand, if it remains fixed, then I know that this will likely be a cervical ectopic. Beyond that, the presence of any of the structures do not help. Of course, the spontaneous miscarriage would never ever, or the inevitable miscarriage would never ever have cardiac activity, and a cervical ectopic, depending on the size, would have cardiac activity. So if you see cardiac activity within the canal, you'll be able to see it. The other thing to realize is that all machines today have presets. This means that in the menu of operating that machine, you can preset so that your machine focuses on the layer, on the region of the cervix, or whether it focuses the entire uterus for you. So if you set a preset cervix, you will get a much better image of what is even closer to the transducer and a better resolution. So do become familiar with the presets on the machine that you use.
At 16 weeks, once abdominal pregnancy was not diagnosed in a place that landed in term, live fetus delivered by CS. How to diagnose abdominal pregnancy?
Yes, you see, if we follow a routine protocol, that means we will look for fetus, we will look for fetal morphology, cardiac activity, amnion, cord, placenta. Also included in our protocol is myometrium and adnexa. So we have to go step by step. If you start looking at myometrium in the abdominal pregnancy, you will not find anything that mimics a myometrium, and the myometrium is absent. You will not find a cervix anywhere. The cervix cannot be there. And of course, then you realize that, oh my goodness, this is a very well visualized pregnancy, and I don't see the normal uterine structure. So you cannot go wrong. So the idea is to follow the protocol of going beyond uterine contents and including normal pelvic and abdominal structures.
Okay, any more questions? Hello?
There's a very important question here on whether Form F is necessary to maintain in 8 weeks pregnancy. Logically speaking, I fully agree with this question that we cannot determine the sex at 8 or 9 or maybe even 10 weeks of gestation. However, in order to make sure that all pregnancies get covered, and because of the illogical mind of the people who wrote this act in the first place, we realized that we have to fill up this, legally speaking, for any patient who comes in and says that she is pregnant. So
in fact, the F form is to be filled in even before the patient enters the ultrasound room.
Yes.
That is what they say. So we don't know she is pregnant by 8 weeks, 10 weeks, 12 or whatever. So I think F form is even before patient enters,
yes.
Right at the reception, the our people, they fill in the F form.
Yes, at registration. And then, of course, if you happen to spot a pregnancy by chance in a patient who is presented with abdominal symptoms, and you're doing an ultrasound scan, if, of course, it is an ectopic pregnancy, then you will complete your scan. If it's not an emergency, it is important to stop your scan, fill up the paperwork, and then carry on. Because you really never know when you have a swoop down from the inspectors from the PCP and DT team. Then why would you want to unnecessarily run into trouble by trying to give a justification? Those people are not scientists. They are people from the administration who may not have a biology background. So my advice to everyone is, if you're doing an abdominal scan for whatever reason, I have pain, and I'm doing a gynae scan, for instance, and I discover a pregnancy, I stop, I fill out a form, unless it's an ectopic pregnancy, then I must make a full diagnosis, because you never know when she's going to burst. We have had patients burst in our OPDs all the time, and they burst during ultrasound as well.
I think, sir, it's only for viable pregnancy, not for missed abortion at 12 weeks also.
It is for every single pregnancy.
Any pregnancy.
Missed abortion also?
Yes.
Yeah.
Yes. Yes.
I think it's written not for missed abortion.
No, it's written for every single pregnancy.
Sorry,
Yeah.
sir.
Yeah.
So there's just one pertinent administrative question. I would ask all the trainers as well as Professor Khurana. Sambit has asked whether he should put all the PowerPoint presentations in the WhatsApp group. I think, what is your opinion? Since it's a program where we want people to learn, can we have the PowerPoints in the WhatsApp group?
I think this program is going into a lot more detail than what people can do when they review a PowerPoint.
Yes.
And the intensity with which our teachers teach and the intensity with which they are able to ask and answer questions will destroy the power, and we will lose that uniqueness. We want people to come forward. We want people to ask questions. We never want anybody to ever apologize for a question that, like Dr. Ranjana just did. No question of apologizing. If you ask a
Feel free to
question,
ask.
if you ask a question, you are no longer foolish. If you don't ask a question, you are foolish forever. So I would rather ask my question and never apologize. And most importantly, I think we need to maintain this interactive forum to make sure. Also, I know that this is going to evolve into a national level program where we will need to have our pre and post polls and give then a certificate of participation. So to maintain that, I would rather that we keep away. Yes, I know it's very useful, but when we have our second module, then people are very welcome to join again. And we'll be only too happy to repeat it for them again.
Those who have missed it, they would like to have the PPTs, but I would say, since this whole thing is being recorded, including the questions and discussions,
Those who have missed can contact me. I can help.
give the link.
Yes.
I can help them. Yeah.
Yeah, we can fill in the gaps, but we
Hello,
can't make
Sambit.
it public. Yes.
Sambit, what is your opinion? Sambit, the
Madam, as of now, we have the plan that we will create a Google Drive folder in the Center of Excellence Google account, and we'll share the link with all the participants and mentors.
I would
So they
agree.
will-
I would
so
agree.
that way they will not only see the presentations, they will also, go
Hear
through
the
all
whole
the
presentation.
discussions that took place.
Yes, yes.
All the discussions which took place are also very important.
Yes,
Yes, ma'am.
and,
The whole thing is being recorded from starting of the pre-poll questionnaire.
excellent. So I think that is the way to go, that we have a unique link and everyone must hear what is the content and the interpretation of the text. Because I have attended several basic ISWA courses, and the way I have seen today's presentation, I've never heard it anywhere in the world explained so beautifully. So this is a very unique opportunity to hear it from someone who has done this work themselves. So definitely.
Clap to Jasmina and all the previous trainers. Thank you, Dr. Khurana, for encouraging our trainers. And really, it's
Dr. Jasmina is assistant professor in AIMS Bhubaneswar, sir.
Bhubaneswar.
Yes, I know. I looked at that and I said, I don't know how she has escaped my attention.
And yes,
She's a wonderful
since
teacher.
Dr. Khurana is there, I request all the trainees who have not become members of the SFM, they have to become, because last time I think Preeti Dubey had said she would share the link. I think she has shared, and we have shared it in the WhatsApp.
Yeah.
So all of them should become
SFM members.
Yes, that would be nice. And we have some very good webinars where a lot of this content is repeated. And sometimes they're more advanced, sometimes they're more rapidly paced. You won't get this brilliant pace of presentation, but you will certainly be able to expand your mind.
So we're going from near to far. We're going slowly with dull people like me, and so that we pick up, go up to better capabilities.
Shama madam knows, she is my teacher, sir.
No,
Yes, I know.
Yeah, she is my teacher.
I have seen her at so many of our SFM programs where she has chaired our sessions, and her knowledge is unique. Her knowledge is in-depth.
no, I'm not that knowledgeable.
And it has the most important ingredient of all, the clinical background. Because ultrasound is an extension of the clinical process.
Exactly.
Right.
And one important thing is when we are dealing with early pregnancy and ectopic, one important feature is pain. Any young woman with pain abdomen, as per Royal Oldham Hospital guidelines, should have a beta HCG done. And and that should ask us, that should make us ask the patient to undergo an ultrasound right at the outset when she has pain abdomen, and even beta HCG, serum beta HCG is extremely important. So the doubling rate, as you said, the UPT may be negative. So serum beta HCG has to be done, and that, but if there is pain abdomen, means it's mandatory to do serum beta HCG, even if she has not missed her periods.
Ma'am, there is another question in the chat box from Dr. Asis Mahanti. Should the word chorionic frondosome be used preferably in early pregnancy?
Yes, there has always been a confusion on this nomenclature. And typically, earlier on, when we used to use low-grade, low-end equipment, and we didn't have so many technological advances, we used to use the word decidua, parietalis, and so on. And then we moved on to the chorion. And then we realized that, okay, there is that transition phase between 9 and 11 weeks where we truly may not be able to differentiate all the time. So if you can differentiate, which is possible in some cases, in many cases, then you use the word. And if you cannot, and it looks a uniform thickness all around, then we don't use the term. It just depends on whether you're looking at something at 9 weeks, 2 days, or 10 weeks, 1 day, and then use the words interchangeably during that time. So both words are justified in that phase, not even 9 weeks, 2 days, maybe even in 8 weeks, 6 days. That's sort of a thing. There's also a request for NT, which of course, as has been announced, will be in our future sessions.
Request for what?
For the interpretation of the nuchal translucency. So that will be part of our 11 to 14 weeks.
Next.
Yes.
Is Dr. Sweta is speaking. Dr. Sweta Singh is our next speaker. She is talking of 11 to 14 weeks.
Yeah.
Hashmukh, hello. Dr. Hashmukh, will you discuss the answers?
Yeah.
Whole
Okay.
question answers.
Yeah. So the first question, number one is the yolk sac is the answer. The B yolk sac is the answer. It guarantees 100. It is positive predictive value is 100% for intrauterine, confirms intrauterine pregnancy. Number two, which one is true?
Sir, just a minute, sir. Sorry, sir, to interrupt you. Sir, in pre-poll questionnaire, only 73% of participants have responded correctly to this question, and in post-poll, it is the correct response is from 89% of participants.
Yeah, it is.
That's a good jump.
Good improvement.
Very good. That's been good learning. And the second question was about which was true about CRL measurement except, and here we've got confused with the English language. So the area, Dr. Hashmukh, are you able to see the polls?
See, for the second question, it is C is the exception. C is the exception.
Yes, and so now we still have to learn a little bit more to realize that we are still getting confused between a horizontal orientation or a longitudinal orientation. And so it refers to the fetal orientation. That was very clear from the question. And the correct answer is C, as we've already heard. And so far only 59%. But this question was phrased to keep your mind racing, to realize that, yes, every word is important. Every word we read, every word we think, and every word we write on our patient's prescription is extremely important. So this question should inspire you to constantly think of every word we use. And then we move to question number 3. Dr. Hashmut, please.
Yeah, number 3, the true feature diagnostic of miscarriage on transvaginal scanning is B is the right answer, embryo with a CRL of more than 7 millimeter without the evidence of fetal cardiac activity. That is the correct answer.
Question 4.
Question number 4 is pre-pole.
No, Sambit, let us tell pre-pole and post-pole difference.
Madam, question number 2, the pre-poll response, correct response was from only 16% of participants, but in post-poll, it is from 59% of participants. And question,
yes, it was a difficult question.
And
question number 3 is correct question response is from only 61% of participants, and it has improved to 71 in post-poll questions.
Now, number 4, all are ultrasound features of discordant growth during 4 to 10 weeks of gestation, except will be the difference between CRL and amniotic cavity diameter of 1 mm, that is the exception, because all others are correct. And number 5, blob sign is the correct answer, because 60% of the ectopic pregnancies will have blob sign. Number 6, NRL measurement is taken between weeks of gestation. Which week? It is 7 to 9 weeks is the right answer, because beyond 9 weeks, till 9 weeks, the fetus is hyperflexed.
I think it's 6 to 9. No, question B.
Yes, the answer is 6 to 9. Yes.
6 to 9. 6 to 9 is the correct answer. Sorry. 6 to 9. C is the correct answer.
B.
That's right.
NRL B.
NRL is C. NRL is C. 6 to 9.
Option
6
B.
to 9 is B actually.
That's option B. 6 to 9 weeks is our option B, and 98% of our attendees got it correct.
In my copy, okay, sorry, it is in my copy C is written, so sorry, but anyhow 6 to 9 is the right answer.
Yes.
So the correct number 7, the correct statement for sonological finding of a gestational sac is we always measure gestational sac, and it is expressed in mean sac diameter. We have to measure in 3 orthogonal planes, and we express it as MSD, mean sac diameter. Number 8, the HCG ratio predicting ectopic pregnancy is the ratio between 0.87 to less than 1.66. I think that is the right answer. HCG ratio from 0.87 to less than 1.66 will indicate
the right answer.
Ectopic pregnancy.
That is the right answer.
Yeah. Number 9, the normal order of visibility of structures sonologically within the normal pregnancy are: the first, it will be the gestational sac. It is a yolk sac, amnion, embryonic. Yolk sac, embryo, cardiac activity, and then embryon. B is the right answer.
B is the right answer.
Yeah, B is the right answer. And number 10,
most common
sonological presentation of ectopic pregnancy is again inhomogeneous adnexal mass with empty uterine cavity. That should be the correct answer.
A.
And the good news is that 92% of our attendees got it right in the post poll, which means that we are moving in the right direction. in achieving to update all our attendees. I think we have to congratulate the whole team for achieving this. You know, a 90% result is unheard of in any teaching session anywhere in the world. So we've obviously developed a model that is going to work the best in any socioeconomic part of the world.
Thank you, sir. Thank you so much.
Hopefully we'll go over to the rest of India with your leadership.
I am sure that this will, because this is such a beautiful program that I'm going to make sure that I do my homework during the program, and even before we are through, we will ask your expertise in organizing this at a national level.
We must also congratulate Jasmina and Hasmukh sir. Jasmina, particularly since you've been a good trainer, you've got good results with the learning, improvement in learning. So actually,
yeah, she has presented it in a very excellent fashion.
Very beautiful.
Very impressive. Jasmina, very impressive. Yeah.
Yes, extremely well done.
Yeah.
So, Sambit has warned us that he would leave us at 5. He would just leave us in the midair at 5 p.m.
Yes, we have 2.5 minutes left.
Thank you, ma'am, for
yes, Sambit.
completing the session today within the limit of 5 o'clock.
I think, yeah, we are just coming. I think we can end now. And thank you, sir. Come again, and we will see each other every session now.
Thank you, sir. Thank you.
Yes, yes.
Thank you. Pleasure to be here.
Thank you.
Jasmina, thank you.
Ma'am, I will share the flyer for next session with
Yes,
time.
immediately I'll give you Shweta's data.
And for information of all the participants, we'll be having the next session on Friday, 3 p.m. as per the regular schedule.
As before, yeah.
Yes, because Saturday is the NNF day. The pediatricians have back that time. That's why otherwise we could have made it Saturday also. But
I think
because of them, we have to settle for Friday. Shall we ask the pediatric people to come on Friday and we can take Saturday, because Saturday is more convenient for Professor Khurana?
It doesn't matter. I can come on Friday as well. This has become a very important part of my life.
Thank you, sir.
Thank you for your encouraging
Very
words.
encouraging for us. So next talk is from 11 to 14 weeks, which is again extremely vital. And we expect all the participants to be there. And Shweta has given her data. She's given everything. And so that I'll give it to Sambit for making the flyer. And
she has made excellent slides also. Dr. Sweta has made excellent slides.
yes.
Yeah.
And they've added videos into the PPTs that you have. So the link is more important instead of the PPTs, because the videos will not be live, no, in PPTs.
Yeah.
It's if it's given in the Google link, then only they can see the whole thing. Not
and
only
listen to the wisdom.
the discussions also. Discussions are extremely important that follow.
Thank you, sir. Thank you so
Thank you.
much.
Pleasure being here.
Yeah, thank you, Dr. Jasmina, and all participants. So we meet again next. Let us wait for the announcement. It is going to be Friday, I think. Yeah.
Yes.
Next. Yeah.
By
Yes,
Monday, the flyer will be out.
Okay.
Yes.
Thank
Yes,
you. Thank you. And
Thank
bye.
you all. I take your pardon and I have to close the session now. Thank you.
Okay. Bye. Bye.
Thank you, Sambit. Thank you so
Thank
much
you
for your hard work.